We're so excited to open up our live webinar series through DHA. We are thrilled to host Dr. Mensah as our first physician and speaker to speak on these critical conditions that we see in our client populations. And the reason we're doing this webinar series is because it's so important to continue to push the exact recipe for serving these critical conditions, any mental and emotional conditions. That could be anxiety and depression, autism, schizophrenia, bipolar disorder, addiction, dementia, neurological disorders, and the list goes on, right? So we are bringing together the leaders in the field for supporting these mental and emotional conditions. And we're highlighting one critical condition every single month. This month, we're starting with supporting anxiety and depression and targeted nutrient therapy. So Dr. Mensah is going to be talking about the core chemistries that he is always identifying in these patient populations and how those impact neurotransmitter balance, brain chemistry, and how we really serve these populations with the most up-to-date scientific research and protocols and testing options that are specialized to our population needs. So without further ado, I'm going to begin to get Mensah on here speaking about these things. And please, everyone, just remember to post your questions in the live Q&A. Mensah is going to be on here live to answer them, and you can talk amongst yourself in the chat. So here we go. Hi, Dr. Mensah. I'm so happy that you are here today with me to talk about how you're seeing these mental and emotional conditions in your clinic and practice, and how you're able to really help those suffering from anxiety and depression by running the same types of core chemistries that you're seeing come up again and again for these patient populations. But first, before we go into that, I definitely want to hear a little bit about your background. I know that you are an expert in the field, and for everyone tuning in today, can you tell me about how you came to doing what you're doing and how you got started?
Well, thank you. First of all, Caitlin, I appreciate the opportunity to share with our audience out there. I think the first thing I usually tell people is that I'm not one of those people who is seeking out answers to questions that have been permeating the universe for millennia, and then found this wonderful process. No, I'm a hardcore skeptic. I don't believe anything anyone tells me.
I love that.
I'm shocked I'm even in this field. I was one of those doctors who adhered to the mantra that we were taught first week in school, which was that med school, which was that, nutrients have no real power. They have no real capacity. They're just there for biological health. And so you can't take too many or too much because it'll get urinated out of the system, or you won't be able to utilize it in any way. It's useless, in other words. So the real story is that I was, quite honestly, very early in my career, broke and trying to get married. I had a wonderful job opportunity arise after residency, and they were going to pay me a whole lot of money. I was going to be retired in like 10 years. And then my colleague, a good trusted friend, no nonsense lady, Dr. Judith Bowman, she invited me to a place that she just started working in. She'd been there a month and saw some amazing things. It was the original Pfeiffer Treatment Center. And so I said, well, what do they do? She said, oh, they're healing schizophrenia, and they're healing autism, and they're healing all these things. And I said, hey, that's fabulous. How do they do it? She said, oh, they use these nutrients. I said, oh, come on, nutrients don't work. You know that. She said, no, it's not nuclear. It's more like molecular medicine. And I said, oh, please, whatever. She said, no, she said, Albert, you've got to come see this. So a little background. I was really an ace in neuroscience back in those days. I mean, my ego was so large back at that time that I couldn't fit into a house. Okay. And so I decided, well, I'll go visit this place. And, if in the worst case scenario, I could teach them a few things, about how they might improve their field. So I got there and I met this fellow half my size, Dr. William Walsh. And within about 20 seconds, I realized that my brain was the size of a pinhead, and that this man was one of the world's most brilliant individuals on the planet. And then I met his psychiatric colleague, Dr. Robert DeVito, God rest his soul. And 15 minutes talking to Dr. DeVito made me realize I knew nothing. This Harvard-trained Dapper Dan of a 70-year-old psychiatrist knew more in his little finger than I could possibly ever know about psychiatry or mental health for the rest of my life. And I was extremely humbled. Long story short, I had to rethink a few things, and I was just going to go back to my regular job that I hadn't even started yet. But they called me and they wanted me to work with them. And I figured, well, you know, either this stuff is the greatest unknown work that's done in the field of mental health, or it's the biggest sham and scam that anybody could perpetrate. So I figured, well, there's a sizable difference between what it is they're offering to work there versus what it is that I was going to be making. And I said, well, you know, I would take a risk. And I've been here ever since for well over almost 2 decades now. So that's a little bit of a longer story, but I really wanted people to understand that the risk I took made a huge difference, because I didn't have a whole lot when I was trying to get married. So I had a sure thing, and then there was this questionable thing. And so I had to go back and tell the sure thing people I can't do it. But the leaps that we made in the other world were tremendous. So that's the longer version of the story, but that's how I got here.
I think that's what counts. I think it's fun for people and practitioners to hear where you came from. It's even more fun to hear that you're a total skeptic, or at least you were. And we thank you for taking that risk, because the time and dedication that you have taken in this field regarding these certain clinical chemistries and their impact on neurotransmitter balance and brain chemistry and the function of these poor conditions, mental and emotional conditions, is such an impactful thing. So I thank you for taking that risk. And I really want to get started. I know you're talking about anxiety and depression today and what you're seeing in these patient populations. And I'm curious if your work has always centered around anxiety and depression, or, I mean, I guess my question is more so, are these two conditions your preferred conditions to treat or work with, or are they just the most common, and that's why you'd like to talk about them today?
Great question. I'm talking about these two because they're the most common. Our work really does span the spectrum of mental health. So everything from anxiety, depression, to schizophrenia, to bipolar disorder, disorders like autism, all of those are in our structural wheelhouse, and everything in between. Postpartum depression, rage issues, et cetera, et cetera, et cetera. They are quintessentially treatable, and that's the best part. So it's not just this. Yes, we've got tons of experience when it comes to anxiety, depression, because they are the most common. But we also have a tremendous amount of experience in terms of all these other disorders as well.
Mm-hmm. Wow, that was a great answer. I'm ready to get going, Dr. Mensah, if you're ready.
I am. Before you start the first slide, though, I want to tell everyone out there, you doctors who are like me, skeptical,
I love this. Keep
good
going.
for you, but let me tell you something. Dispel everything you ever heard about nutrients from traditional medicine, from medical school. I want you not to think about nutrients, because nutrients sounds like nutrition. I want you to think about molecular medicine. Our field is ortho, the other side, orthomolecular medicine. Now, to fix broken parts, you need to use the same parts, but in the right concentration. That's what I want you to think about, because our issues are truly at the molecular level within ourselves, whether it's anxiety, depression, schizophrenia, or otherwise. If you can keep yourself focused on that concept and push back all the mythology into which you've been trained to believe was dogma and truth, you may get somewhere. Let's go ahead and start, Caitlin.
I love that. Powerful, Dr. Mensah. Here we go. I'm going to share your slides. You just let me know when you're ready for the next one, and we will go from there.
So here we're talking about anxiety, depression, and Dr. Judith Bowman, who's there, is she's the lady who brought me into this field. My trusted friend. We were part of the same brat pack back in med school, and she was the only one of our group who was just that kind of serious that could draw me into a field like this and get me to take that next step. So she deserves a tremendous introduction here. And so Dr. Judith Bowman, Dr. Albert Mensah, anxiety and depression. Next slide, please. All right. So all of us have heard about neurotransmitters, obviously. We're trained in that. That's what we use to kind of manipulate mental health disorders by way of pharmaceutical medications, excuse me. Now, here's the interesting thing, though. We think about most of these medications, and what they do is that they basically stop the destruction of neurotransmitters. But the question is, how much of what we do involves helping the production, the actual production of neurotransmitters, or the activation of neurotransmitters? See, we forget, but we were taught this even in school. Neurotransmitters are produced, but they have to be activated and they have to be deactivated. So what we're seeing now and understanding is that what orthomolecular medicine does is that it focuses not only on production, but activation and deactivation by molecular keys. And so if any of these molecular keys are not appropriate in balance, presence, concentration, then what we see an offsetting of appropriate neurotransmitter activity. So there are distinctive biochemical imbalances that are exhibited by most people with anxiety, depression, or mood disorders. For example, copper-zinc imbalance, undermethylation, overmethylation, a condition called pyrrole disorder, toxic metal overload, or severe oxidative stress. Next slide, please. Now let's talk about some deficiencies that impair brain function. Now we're going to go through a list and then we're going to deal a little bit more intensely with each one. The first one is zinc, my favorite of all the molecules out there are nutrients. Then there's methionine, folic acid, vitamins B6 and B12, niacin and niacinamide, DHA, some of the essential fatty acids, and then certain antioxidants like selenium, glutathione, vitamin C and E, etc. And of course, chromium. Next slide, please. Now, those were deficiencies. Let's talk about some overloads that can impair brain function. Too much copper, too much folic acid, too much iron. Now, before we talked about too little methionine, but you know what? Too much methionine can also cause problems, as well as S-adenosylmethionine, or SAMe. And then there's certain toxics that most of us have talked about in the past, lead, mercury, cadmium, etc. But these are very important. Overloads in these particular agents are oftentimes the root cause of some very, very severe cognitive disorders. Next slide, please.
Dr. Mensah, can I ask a quick question about this one?
Yes.
Have you seen an increase over the years in your practice of these overloads in your patient populations? I'm asking because I think there's like a supplement culture that's rising. And I think we are at a nutrient deficiency as a population, but I think at times we're over supplementing and not with the right formulations of these nutrients. So I'm wondering for you as the physician, if you've seen that increase.
Oh, absolutely. Absolutely. And let's talk for a moment, just a quick deviation, talk for a moment about dietary overloads.
Yeah.
So we've gotten to the world of extremism. So instead of eating a balanced diet, we say, oh, well, and let me be fair, I am not a proponent, a hater, or a lover of any given dietary regimen. I'm just a scientist, well, in theory. But when we go extreme, kale, spinach, broccoli, avocados. Okay. Does that sound familiar? How many
Definitely.
people eat salads maybe twice a day with those particular agents? Okay. Everything I mentioned just now has got folic acid or copper. And most of the individuals who eat this particular, in this particular way are females who, by the way, have anxiety or depression. Okay. And so they go from perhaps a balanced diet. They want to eat cleaner, eat healthier, because that's what we were told is a healthy diet, more veggies. And then what we come to find out that those veggies are rich in copper. Copper is not your friend. I'm going to give you a little bit of a hint here. Copper is a key molecular agent that converts your neurotransmitter dopamine. Oh, he said neurotransmitter. Now we can listen because this is a science thing. It converts dopamine to norepinephrine, also known as adrenaline. Now, doctors, I want you guys to think for a moment. Adrenaline, right? Norepinephrine. What receptors does this actually hit? It hits the beta-1 receptor on the heart, the alpha-1 receptor in terms of peripheral vascular issues, and the alpha-2, to say the least. So now, what does beta-1 have to do? Increases heart rate, okay? That's part of the fight or flight response. But what if there is no danger? You develop anxiety, and over time you can develop depression. That's right. So let me say this again. Somebody who's prone to anxiety and depression, eating a high vegetable diet rich in those 4 food categories, especially avocados, is high in copper that can worsen your anxiety and depression.
Wow.
That's just food, okay? So there's a whole paradigm shift that needs to happen here, okay? And yes, we see a tremendous amount of it. And interestingly enough, the people who should be eating more dark green leafy vegetables are interested in eating more protein. And the people who need to be eating more protein are shifting to dark green leafy vegetables. That great mystery I haven't yet solved. I do not understand it. But here's the deal. These particular agents, we're seeing lots of this, and it translates not just from mental health, but also women with fibroid tumors, endometriosis, and even breast cancer. These particular agents are key and involved. We do treat those or support those challenges as well.
Wow.
We'll go to the next slide and we'll dig in a little bit deeper. Okay. I'm going to skip this slide. It's just a little bit wordy. We'll come back to it.
Sure.
I wanted to show a slide involving what we call biotypes, for example, of depression. So we think about depression for the most part as just one giant condition. But the fact is there are multiple causes for depression or depressive tendencies. Okay. Well, if you look at the light blue area of the graph, we see a condition that says 38%, and that is called undermethylation. So most of depression, or significant amount of depression that we see, is actually rooted in an undermethylation phenomenon. 20% in that red area is due to a folate deficiency. The green area represents copper overload. Remember, we just kind of gave a hint about copper, but that number is actually a lot higher these days than it used to be. For example, when we did these slides originally, in the last 5 to 7 years, there's been a drastic uptick in the consumption of copper-rich foods and in the utilization of estrogens. So guess what estrogen does to copper? It causes copper levels to rise. And so in an estrogen-dominant female, or shall we say a copper-toxic female, we see everything from mental health challenges like anxiety and depression to actually organic syndromes like fibroid tumors, endometriosis, breast cancer, and even fibrocystic disease. These are all related to copper issues. I know that's a shock. Many of you are going to say, oh, I don't believe that. Well, trust me, believe it. We can talk about it any other time. That purple area, pyrrole disorder. That's a one that many of you have heard of. Quite a few may not have heard of it. It's done and evaluated by a simple urine test. This is what I call the Bruce Banner Incredible Hulk syndrome. Instant rage, temper, poor and very slow to settle. This is a disorder of stress intolerance, but it can also cause depression or anxiety, and that's 15%. Then we have an honorable mention to 5% toxic agents that are out there, and then 5% other things. So this is a very important slide in terms of understanding that depression is not of one type. And to get to the root causes of depression, truly, you got to test for these particular conditions to determine how you target or treat the patient. Next slide, please. When we did this, we used to talk about copper zinc imbalances, but as we've been training physicians for the last 15 years or so, what we come to understand is that physicians, you guys are all too heady, too technical, too smart for your own good. And you start worrying about ratios and completing ratios. I don't want you to think that way. I want you to think about copper separate from zinc. So I want us to actually bypass this slide. But a lot of you are being told about copper zinc imbalances, and that's not how you want to think about it. Because you can have a 1-to-1 ratio of copper to zinc. Let's say your copper is 125 and your zinc is 125. Guess what? You're going to have copper toxicity issues. The zinc does not balance it 100%. So let's move beyond the slide, and folks, even just forget I ever put it up there. Okay. So let's talk for a minute about percentages, because you guys all like percentages and so forth. In the general population, 70% of individuals actually exhibit normal methylation, but 22% are undermethylated, and about 8% are now overmethylated. Now, here's the thing. That's in the general population. About 70% of individuals who have so-called mental health disorders exhibit a serious methylation disorder. Next slide, please. Let's talk about overmethylation. I know that those of you out there who are saying, oh, we were told that there's no such thing as overmethylation, just undermethylation. Well, folks, there's balance in the universe and there's balance in the system. Where there's undermethylation, there can be overmethylation, and we see it all the time. Patients who are overmethylated have a tendency for high panic, depression. Overmethylation is associated with activity, as well as intolerance to SSRIs. Now, did you guys just hear what I said? Intolerance to SSRIs. Doctors, we're talking about your medication failures here. We all know that quite a few patients respond wonderfully when they are depressed, and we give them their SSRIs or SNRIs or other antidepressants. But we're very puzzled by those medications that don't seem to work or actually make the patient worse. Well, the reason involves methylation. And over-methylated patients don't respond well to SSRIs. Let's think about this. If you see, read that last line there on the top, over-methylation is associated with increased serotonin and dopamine activity, right? So if somebody has got increased serotonin and that's causing a problem, why would you give a medication like a serotonin-specific reuptake inhibitor, which increases the level of serotonin, when serotonin is actually part of the problem? This is why you've got to know about overmethylation. Okay? Let's talk about some honorable mentions in terms of the symptoms of overmethylation. Anxiety, depression, self-mutilation, high pain threshold, low motivation in school. Here are the big ones though. Artistic or musical ability, paranoia, obsessions without compulsions, okay? Now, the personality types of the overmethylated are what we call the artsy people in the world. These are our theater majors. These are our musicians, composers. These are our actors and actresses in Hollywood. These are our writers who come up with these amazing scripts, usually powerfully overmethylated folks, high serotonin activity. Their brains just spin faster than light all the time. The problem is that it can lead to anxiety and depression. Next slide, please. Let's talk about undermethylation. Now, folks, when you hear about OCD, perfectionistic personalities, you need to think immediately about undermethylation, okay? Most undermethylated depressed patients exhibit classic low serotonin symptoms and report improved moods after using SSRI medications. So see how the balance of the universe is working. Overmethylators respond poorly to SSRIs. Undermethylators respond well. Overmethylators have high serotonin activity. Undermethylators have low serotonin activity. Okay? Now, note what I said. I said serotonin activity. I did not say serotonin concentration. These are different things. Methyl molecules activate enzymes, hormones, and neurotransmitters. So if you have 50 million neurotransmitters out there, but you only have 100 methyl molecules to turn them on, you're going to have low activity because you don't have enough methyl to cover all the chemical reactions needed. Let's look at some of the symptoms here. Obsessive compulsive tendencies, very low tolerance to pain. These people have ritualistic behaviors. They're very strong-willed. These are our icky, ticky, picky individuals who are basically control freaks. They're perfectionistic, and that is a huge thing for them. Why do I say that? Because most of you listening to this program right now are undermethylators. Yes, doctors, lawyers, engineers, school teachers, secretaries, right? You know the ones. Mr. or Miss Johnson, I need the, here you are, sir. Here's your chart. Here's your schedule. Everything is done. It's quintuplicate. High perfectionism, very organized, usually undermethylated, okay? They can have a very calm demeanor on the outside, but high inner tension on the inside, okay? All right, next slide.
Before we go on, I want to say you're really calling out the viewers and attendees here, Dr. Mensah, all of us, you know, health entrepreneur, high achieving, undermethylating health practitioners. It's funny, but you're right on. You're right on. Next slide.
So when we test for methylation, the one I really want to share with you guys is the whole blood histamine test. And that's probably the best way to understand design. So here's something I want you guys to think about. How you're designed versus how your body is working. They're not the same things, okay? Now, there's several tests that are out there for methylation, but I want to share with you the histamine test, the whole blood histamine test, tells you how you were designed. But this SAM-E-SAH ratio test tells you how your body is performing. They're not the same. So for example, the SAM-E-SAH ratio can be altered by nutrients that you take into your body. If you're eating lots of dark green leafy vegetables, you're going to change that SAM-SAH ratio, but you're not going to change your whole blood histamine. Okay, so that's why each test is a good test, but each one has got its foibles. Okay, I want to share with you this concept. We'll talk briefly about SNPs a little bit later, but that's what I want you to remember. The best test to determine how a patient was designed is the whole blood histamine test. If you really want to know how a patient is actually performing inside, then you do the SAM-SAH ratio, okay? Each test can be shifted a little bit by different things. So for example, antihistamines can affect the whole blood histamine test, but they have to be powerful, like 3 or 4 SSRIs or anti-allergy medication that involves immunoglobulin therapy. The SAM-SAH ratio can be affected by taking too much supplements. For example, Too much methionine can throw off that test. Too much folic acid can also throw off that test. Okay? The combination of the two gives you a great picture. It tells you design originally and function. Next slide. All right, now here's a big one. And I need you guys to settle down and just listen to what it is we have to say. The truth about genetic mutations. That bold area is where I'm going to shock you right now. Most SNPs have little or no effect on enzyme function. And you're thinking like Scotty from the Enterprise. Great, Scott, what do you mean that we they have very little function or effect? Everyone's been taught about SNPs and the MTHFR and blah, 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 blah. No. Folks, remember, let's be scientists for a minute here. You study genetics. You know that mutations happen in our cell structure and our DNA all the time. And those mutations get repaired. And most of the time they have very little function, very little effect in our bodies. Okay? You forget about the size of the molecule. The larger the molecule where the SNP is present, the less significance the SNP has on the enzyme function. Okay? The smaller the molecule or enzyme, the greater the significance a SNP has on enzyme function. But I want you to remember this. Genes and genetics is a promise. What happens in chemistry is the execution. So if you do gene testing and you depend on genes and gene testing for your diagnoses and your truth, you're going to be shocked, because most of the time our bodies are not always functioning the way our genes are saying they should be. Now, what's the validity there? This little known field that's rapidly growing known as epigenetics, and I'm being sarcastic. All of you have heard about epigenetics now. Transgenerational trauma, environmental stressors, how the environment affects genetic expression. All of this is about how the environment changes your DNA expression. Okay? So you may have one gene that says this, but your body may not be doing that. If you don't believe me, I want you to think about identical twins. Pick any set of identical twins that you know and ask yourself the question as a physician, are they exactly alike? Don't you notice some are usually a little bit thicker than the others? Some are actually taller than their twin. Some actually look significantly different. But their DNA, their genes are exactly the same because they started off as the same egg, so they have the same DNA. So why is it these minor differences occur? Epigenetics. The environment changed genetic expression in one of the twins. Okay? Next slide, please. Well, I kind of just went through that regarding gene testing. Next slide, please. Let's talk about pyrrole disorder. This is one of the most common disorders prevalent throughout the entire world. Pyrrole disorder ultimately results in a double deficiency of zinc and vitamin B6. And this leads to a tendency for low brain levels, I said brain levels, of serotonin, dopamine, and your calming neurotransmitter, gamma aminobutyric acid, or GABA. This is a recipe for depression and anxiety. Now, I know you guys are thinking, well, wait a minute, what does zinc and vitamin B6 have to do with low levels of serotonin? Here's what they didn't tell us in med school. So I want you guys to go back to the synthetic pathway for serotonin. Sure, there are the enzymes, and we were told the rate-limiting enzyme is the key in terms of production of serotonin. Well, guess what? The rate-limiting enzyme is more like a horse. But the cofactors in that reaction, zinc, vitamin B6, vitamin C, they are the riders of the horse that guide the horse. They can increase production, or if they're not present, slow down the horse's gallop. So zinc and B6 are needed for the production of serotonin. When you are low in zinc or B6, you end up with low concentration levels of serotonin. And that's one way you can get depression. Okay? So just remember, Our brains are wonderful factories of production for neurotransmitters, but the raw materials they use for that production are nutrients, vitamins, and certain metals. And now we're seeing the core pieces. This is why we call this molecular medicine. All right, symptoms of pyrrole disorder. What I want to share with you is that the real symptoms of pyrrole disorder are rapidly cycling mood states, anxiety, depression, rage, agitation, and these are extreme, sometimes histrionic in behavior. Some interesting little tidbits. Individuals may have sensitivity to bright lights. Now, you guys have seen them out there. These folks are indoors and they're wearing sunglasses. Now, when I was little, I remember seeing these folks in stores and homes and in schools. And I was like, oh, these people think they're so cool. Why are they wearing those glasses? I mean, come on, man. You can do better than that. Get humble. Take the glasses off. But when you spoke to them, they would tell you, my eyes are sensitive to the light. Now, that was years before I ever knew anything about pyrrole disorder. But now we understand these folks have an issue, a chemical issue that makes them light sensitive. Okay, and they're not albinos. They're pyroluric. They have pyrrole disorder. Morning nausea can oftentimes be a symptom of pyrrole disorder. Most of these folks will tell you, well, I generally skip breakfast. I don't do that too much. I eat more lunch and dinner. That's one of the potential symptoms. Okay. Severe depression, inattention, delayed puberty. Why delayed puberty? Because zinc is necessary for physical growth. And so without zinc, you're just not going to see a whole lot moving, both physiologically or physically, when it comes to the development of a child, especially young males. Histrionic behavior, oftentimes very, very, very quintessentially pyrrole disorder. Next slide, please. I'm going to skip over toxic metal overload. It is there, but it's also, as we talked about, only about the 5% when it comes to anxiety and depression. So we'll kind of pass by that one. Oxidative stress. Man, this is like in molecular medicine these days. Oxidative stress is the buzzword that's present in everything from anxiety, depression, to truly autism. Oxidative stress, think about it as cellular rust. It depletes the system of glutathione, which is needed for efficient NMDA receptor site function. It destroys digestive enzymes that are needed to break down casein and gluten, and it produces inflammation that results in the leaky gut that we all talk about. Leaky gut allows toxins to enter our bloodstream. That can affect mental health. Additionally, severe oxidative stress can lead to poor immune function and disruption of the methylation cycle. A lot of moving pieces here, but they're all connected. Identify the pieces and you put together the connection. Now you've started the process of healing. Next slide, please. So let's look at what we would do in terms of a comprehensive evaluation. What we talk about first is we're thinking, what is really out of balance here? Do we have nutrient overloads or nutrient deficiencies? Do we have metal regulation or metal dysregulation? Do we have environmental and or epigenetic factors? We have GI issues, including food allergies, sensitivities, and malabsorption. You want to test for methylation disorders using the histamine test. And then there's, of course, pyrrole disorder, looking at zinc and vitamin B6 imbalances. Next slide. So in our overview process, the first thing we want to do is listen. The patient will pretty much tell you, when you listen long enough, as we've been taught, exactly what's going on with them. So we do an extensive patient history. Then we do, of course, a physical exam. Now we get to the heart of the matter, no pun intended. Specialized laboratory testing. We do blood, urine, and even hair analyses. We evaluate diet and GI issues as well. And then the core here is that we use advanced nutrient therapy protocols. I started shifting this a little bit around. I should change the slide to advanced molecular medical therapy protocols that are prescribed at appropriate therapeutic levels to target the patient's specific needs in order to correct underlying biochemical imbalances. And docs, let me tell you out there, when you correct the underlying chemical imbalances, it's as though there's an inverted domino effect from the ground all the way through to the brain and the mind and the heart and the spirit. People get better because you started from the actual root causes of their disorder. And then the system fixes itself. You don't even have to be that smart. I don't have to be that smart. All we have to know is what these key points are, correct them, sit back and let the body do its thing. That's why I love this process. Next slide. Okay. So what I want to do now is I didn't prepare that slide for you, but I want to talk about any given case. So let's just pick one. Doctors, you know how this goes. Just pretend you're back in residency class, or residency. So let's say we've got a 35-year-old male who comes to you with anxiety and depression. He's a graduate student. He has done well all of his life. He's a straight A student. And he did a few things in college that might have been slightly problematic, but they weren't huge. A little bit of marijuana here and there. Had great number of friends, comes from a very, very wealthy background. He has no reason to be anxious or depressed. He's got a wonderful significant other. Life otherwise should be great, but you know what? He's having a very difficult time in graduate school. He's having trouble sleeping. He's very moody. He's anxious and he's depressed. So he comes to you and he says, "Doctor, help me, help me, help me. I don't know what's wrong. My life really should be perfect. Got the graduate school of my choice, but I'm just struggling." And I'm going to mention to you that this gentleman's mother is Irish and father is Scandinavian, comes from Sweden. Now, why did I bring that up? Because there's something I didn't tell you before. There are two genetically powerful pyrrole disorder components globally in terms of populations: the Irish and the Scandinavians. These individuals are genetic pyrroles. You can have genetic pyroluria and you can have acquired pyroluria. Any form of stress causes pyrroles to rise. And so now let's look at the scenario I just talked about. Is this fellow stressed out? He's in graduate school. Of course he's stressed out. Okay. But then here's the thing. Mom and dad, I should just say, fall into those two populations of pyroluria, the Irish and the Scandinavians. Most of you don't realize the fighting Irish, the stereotype of Irish folks as being short-tempered, always ready to go to battle, drinking beer, all these things, that rage effect, it's pyrrole disorder we've been talking about in the movies, in the cartoons, and even in the logo of Notre Dame's Fighting Irish. Okay? That's where it comes from. People just don't realize it. I've been to Ireland. We've tested these folks. We know for a fact the vast majority of these individuals are pyroluria. There's no question. So I don't mean to be a sexist, but for those of you out there who just saw that lovely, fiery, red-headed, beautiful young lady with that strong spirit, guess what you're looking at? You're looking at a pyroluria female. And those of you parents who have just adored your lovely blonde-haired, blue-eyed little boy who looks just like Uncle Sven, guess what? His little rageful self at age 2, the terrible twos, it's pyrrole disorder. Okay? Let's get back to this fellow. So you hear the buzzwords. First of all, he's a graduate student. He's always been an A student. Well, that tells you he's perfectionistic. And you ask him about his perfectionism. Actually, we just tell him, you're probably perfectionistic, aren't you? You go, oh, yeah. You know, I was valedictorian in this class in school, and when I got to here, I was salutatorian there, but I missed it only by like half a point. You can see the competitive nature under methylators, okay? Now, what we see next is that he's struggling because of environmental stress. Well, stress is what causes pyrroles to increase. That stress can be environmental, it can be physical, physiologic, or social. So Where is he now? He's in an environment of a high stress, namely academic achievement and academic pressure. That's social. He's got relationships. That is, of course, another pressure. So immediately you sense he's more stressed than he should be. Hence his pyrrole levels are rising. Remember what we said about pyrroles? They deplete your body of zinc and B6. What did we say pyrroles or zinc and B6 do? They're part of the creation of serotonin, dopamine, and your calming neurotransmitter, GABA. So if you don't have zinc and B6, or if you have pyrrole disorder, which lowers your zinc and B6, you're going to have poor neurotransmitter production. But it's not just production. Remember, we said he's likely an undermethylated person, which means he doesn't have enough methyl molecules to properly activate the very serotonin he so needs. So now we have poor production and we have low activation. And we wonder why he's depressed. Obviously, with low GABA levels, what do you have to combat the anxiety that's in your environment? Not much. You can't produce GABA, and even if you could, you couldn't activate it because he has pyrrole disorder and undermethylation. Not enough methyl molecules, not enough production. Okay? So this fellow is struggling, despite his brilliance, to make it through his world because of everything that is going on in his environment. So what do? Well, we've heard his history. So now we go to our little laboratory sheet and we choose, let's check for methylation with a whole blood histamine test. Let's check for pyrrole disorder with a urine test. Other things we would do include a hair analysis. We'd look at copper. We'd look at a few other things as well. But quintessentially, him showing up and just talking to us has pretty much told us what's wrong with him. And folks, you and I both know there are tons of perfectionistic folks out there. Most of us didn't get to where we are without being somewhat perfectionistic. This fellow could easily have said to you, I've got OCD. And he would fall right in that same category as well. Okay. And if you ask family history, well, you see, I come from the family of just superior beings. My father had 3 doctorate degrees. My mother, of course, had 1 doctorate, and then she got her master's at age 50 and then went on to get her 3rd degree when she was, 65. And I've got 5 siblings, and everyone has nothing less than a master's degree. Guess what runs in that family? You think it's just rote brilliance, don't you? No, it's undermethylation. That drive that allows individuals to get there. I'm going to share with you something else. Sports. Michael Jordan. I think most of you know who Michael Jordan is, but younger folks may not have really been able to see him play back in those days. Michael Jordan is one of the most competitive personality types on this planet. Okay. As far as athletics and other things are concerned. Extremely competitive. It was that competitive drive that actually let him move from a fellow in high school who didn't even start on the basketball team to becoming one of the greatest basketball heroes ever. He's severely undermethylated. Severely. That competitive drive. So we tested chemistry. We found this fellow to be an undermethylated pyrrole individual, like we said, with low zinc levels. Correcting those issues, and here's the thing, it's so statistical. We know that pyrroles tend to clear anywhere between 3 weeks and 3 months. So if pyrroles are the main issue with regard to someone's depression or anxiety, it'll be better within 3 weeks to 3 months time. Just like this. If it's undermethylation, on the other hand, that's the exact opposite extreme, which is why I wanted to talk about these two. Undermethylation takes anywhere from 8 months to a year and a half, depending on the condition. So it's faster and easier to treat an undermethylated schizophrenic, for example, than it is to treat somebody with OCD. It takes them about a year and a half of consistent, just taking your protocol, okay? So they're not just identifying marks that guide your pathway. It also tells you basically how long it's going to take for someone to get better. And then you want to test in between so that you can gauge the progression. Your low zinc level should be coming up. your pyrroles should be coming down over the course of 6 months to a year. Methylation, if you want to use a methylation profile, you can then help identify literal levels of the various agents that are changing that will affect mental health. Okay. There are trillions of different examples we could give, but I wanted to start you off with a couple of very, very significant pieces because we all encounter them. Anxiety, depression, number one, they're not the same thing. Okay, these are disorders in people that can have several different causes. So what do I mean by that? We focused on pyrrole disorder and we focused on undermethylation. Truth be told, if someone said, what are the biochemical causes for depression? I would say, oh, okay, let's start with undermethylation. Then there's the opposite, overmethylation. Then there is low vitamin B6 and zinc. Then there is high levels of copper. Then there's actually some significance with regard to dietary challenges in yeast disorders, excess yeast in the GI tract, leaky gut challenges, okay? We can also talk about environmental issues that lead to pyrrole disorder and an increase in pyrroles that lead to now depression. Depression is not one diagnosis. Depression is a label that we, in our infinite brilliance in psychiatry and medicine, decided to just call something. Well, you're not happy, so you're depressed, with no scientific background to substantiate that concept. But now what we see is that depression is actually several disorders, any of which can produce the same symptomatology. That's why in order to actually fix the problem, you've got to know what the cause is. And that's where biochemical testing comes into place, like what we do with Direct Health Access Labs. And that's what allows us to actually truly change lives. Okay. So I think that's a good, significant introduction to that world. I wanted to share with you all that, look, we do this every day. This is our specialty. It's not part of our practice, it is our practice. And that's what we do to help people. For those of you who are having trouble, who are stuck with your protocols, your pharmaceutical medications, I'll also share with you, you don't have to take someone off of medications in order to do this process. You can literally use them in conjunction with medications. But what you're going to find out is that as patients do better, a lot of them are just going to actually kind of want to wean away, and they'll tell you, I think my medication is too strong. And you'll say, okay, well, let's lower the dosage. And eventually you'll find yourself lowering them to the point where they don't need them anymore. Okay. It all depends on a variety of factors. But here are the big things I want you to remember. First of all, there is a root cause, and there's a root cause analysis for anxiety and depression. Number two, the testing is just easy. Number three, on paper, the treatment is not that hard, but you've got to be able to identify what it is you want to treat and then put together the right protocol with the right doses. Everything is dose dependent. They don't think you just throw some zinc into the equation based upon recommended daily allowance and that's going to fix it. It's not. It is not. You need the right concentration. It's usually very, very strong levels by traditional standards, but not by ours. And that's what does the key. So people think, and I want to give you an example. If somebody's got a migraine headache, are you going to give them 200 milligrams of ibuprofen in terms of an adult 300-pound male? No, you're not. You're going to use at least 800 milligrams of ibuprofen 3 times a day in order to treat that person. Same way, you're not going to give somebody who's an adult male 5 milligrams of zinc like an RDA and think that you're going to correct a zinc deficiency or pyrrole disorder. You need several times that. I'm not going to give you the number because I don't want you guys going out there and trying this on your own. You need some training. Okay. But the deal is this. It's treatable. It's identifiable. People get better. If you don't believe me, then be exactly like me, because I didn't believe what anyone was telling me either. I had to prove them wrong. And in me trying to prove people wrong, I got humbled and learned they were right. So for all my doctor colleagues out there, please, please don't believe a word I just said. Do it for yourself. See what happens. I'm Dr. Dr Mensah, for Mensah Medical and Direct Health. Thank you.
Thanks, Dr. Mensah. That was so great. I know I personally have a lot of questions about some of the stuff you covered, and we've had some really good questions come in from the audience. So I don't want to wait any longer to get into the live Q&A. Hey, you guys, we are so excited um, about that presentation by Dr. Mensah. We had so many great questions come in. I could not be more thankful for the questions that keep on coming. As far as everyone that's still posting in the chat, please post your questions in the Q&A because that is going to help me give them to Dr. Mensah when he hops on. You might have seen them. Reed Davis says, have to go. Bye, everyone. Bye, Reed. We love you, and thanks for coming. Dr. Mensah should be here with us shortly. He's having a little bit of computer problems, and you might have seen him hop on here in his little thumbnail, and we are just waiting for him to get back. So he should be back pretty soon. And until then, Da, 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 da. Yeah, gosh, there are so many great questions. You guys, please keep posting them in the Q&A. Right now we're at 22, and Dr. Mensah said he would stay on as long as it took to get through them all. So I think we should monopolize his time, and I hope you guys agree with me. Whenever he gets here, we will get going. Really good feedback was coming in during that whole event there. I know some people are dropping off now. I think Dr. Mensah should be on in the next 3 minutes or so. And once he's here, we will be able to ask him some questions live. So stick around and we'll be able to talk to him shortly. Yes, so people are asking about the live Q&A. I know if you have to drop off, it's okay. We will be sending out this recording in the next couple of days. My goal is to have it to you by the end of day Friday. Maybe it's the end of day tomorrow, but Friday for sure, and you'll be able to tune in to the live Q&A there. So that is my plan, and we're so thankful that you could come to the presentation side of things with Dr. Mensah and myself. Yeah, Reed brought up a great point here. He mentions the right testing. Of course, the right protocols are going to be important, when we are seeing patients and clients within this, depression and anxiety realm of things, as well as other mental and emotional conditions. But of course, first we have to test to ensure that we're able to select the right protocol. Is there training that we can do? Please give more info on that. So thank you. This is a great question. I have plans very soon to email out a very special training offered by the Walsh Research Institute that is going to really help. Oh, Dr. Mensah is popping on right now. More to come on training, and I'm also going to ask Dr. Mensah that question. So, Dr. Mensah, can you hear us? He is muted, but he is looking to unmute. So at the bottom left of your Zoom window, Dr. Mensah, there should be a little microphone. If you click it, it should unmute you. He's talking, but we can't hear him yet. He's coming soon, you guys. I'm so excited.
There we are. Okay.
There we are. Dr. Mensah, how are you?
I'm fine. How are you?
Oh my gosh, I'm wonderful. We're so excited to see you. And we had so many great questions come in during your presentation. I'm super antsy to get going. And I just wanted to thank you before we get going because we've had such good feedback during this training already about what a great speaker you are. And DHA is so happy to highlight you as an expert in this arena for our first episode of our live webinar series. So here we go. Without further ado, I'm going to start from the top with questions. Dr. Mensah, is there a center offering support like the Pfeiffer Center for Schizophrenia Recovery on the West Coast? Or can we send and coordinate care for clients who need comprehensive schizophrenia recovery support to you via telehealth?
The answer to both of those actually is yes. So Mensah Medical comes to California, both Northern and Southern California, twice a year. And that's typically okay. But if you want to get started immediately, Mensah Medical does that support by way of telehealth. So usually we start with a telehealth appointment, and then the next time we're in either Northern or Southern California, then we can see the patient directly, and it's usually within the span of 6 months or so. So we get good comprehensive care. We get you started, and then we move you forward as well.
Excellent. That's really great to hear. Another anonymous question. After a patient has been through anorexia, binging, and other compulsive eating disorders, how do we reset the neurotransmitters, GABA and glutamate, to single hunger satiety via orthomolecular methods? That was a mouthful.
That's a great question. And first of all, it goes back to our testing process. So in traditional medicine, we think about neurotransmitters and how we stop them from being destroyed. So we have SSRIs, serotonin-specific reuptake inhibitors, to allow for a greater concentration of serotonin. Now, the same thing is actually true of GABA and glutamate. How are we not preventing them from being destroyed is the question, right? Wrong. That's the wrong question. The question we answer is, how do we increase production? And we increase production of those neurotransmitters by giving them the source materials which they need, involving zinc, for example, and vitamin B6, in the right concentrations for each patient. Now, when you do that, you're automatically increasing levels of GABA. So now, once you've done that, there are two parts usually to treating individuals who have anorexia or an eating disorder. The first part is in stabilizing chemistry, because for many, it involves the push from chemical imbalances that lead to anxiety, that lead to depression, that lead to a variety of things that lead to the eating disorder in the first place. So baseline is get the chemistry straight, and then there's a domino effect whereby the neurotransmitter levels now balance out. So you've got a balance between your calmers and your excitatory neurotransmitters. Now, once that's done, the patient often responds much better to actual therapies like psychological therapies or behavioral therapies, dietary modification, and suggestive therapies that are supportive from a psychological perspective. One thing we forget is that every time the brain goes through a neural arc, that is a continual reflex of thinking, it sort of digs a groove in the brain from a physiologic perspective. In other words, the more you do something, the more reflexive it becomes. That has got to be undone, but it cannot be undone without first balancing the chemistry. So yes, there are the neurotransmitters, but then you have to undo the pattern. And that pattern usually involves support from a psychologist, a psychiatrist, or a therapist of some type. But they're in a much better place to receive that support and for that support to stick.
That was a great answer, Dr. Mensah. Thank you. Moving on to the next question. Can you speak, this is a good one. We had a lot of questions come up re folic acid. Can you speak about the distinction between folate, folic acid, and folinic acid in terms of exogenous intake? Not only overloads, but also possible SNPs that cause even greater problems with this.
Okay. First of all, I have to share with you, there's a lot of misconception around folic acid. Most people are talking about MTHFR whenever they start talking about folic acid and folinic acid and all those things. And first of all, I'm going to tell you guys something that is very shocking to most of you. The MTHFR is the wrong concept. It is wrong on so many levels, it's not even funny. And that's why most of your failures are occurring if you're trying to use methylated folate, folic acid, or folinic acid to treat someone who's supposed to be under methylated, because that's what MTHFR is supposed to show you. I'm going to give you a couple of reasons why MTHFR is not correct. First of all, MTHFR is a singular enzyme. It does not basically craft what is your methylation status. There are 8 enzymes involved in undermethylation in a tug of war with 8 to 12 enzymes involving overmethylation. It's the combination tug of war of each one of those agents that leads to your methylation status. That's one of the reasons why the MTHFR as a concept is actually incorrect. The second reason is that genetic SNPs are promises. They're not actuality. They're actually potentials in your system. They're not necessarily reality. So how are you determining the actual functioning of an enzyme based upon a SNP? For the most part, is not correct. Okay, that's why we look at the chemistry. We don't look at genes per se. We know about the genes, but we recognize, first of all, you're testing one way for the genetic pattern, but then your chemistry says something different. We have lots of people who got MTHFR double homozygous, and guess what? They're over methylated people, not under. Now let's get back to the folic acid question. So folic acid, folinic, and folate. Basically, the short end of the story is they all turn into the exact same molecule inside the cell. Now, I know what many of you are thinking. Well, no, I read that, by the way, folic acid will get into the cell faster, and folinic acid takes longer, and folate is in between the two. Well, here's the thing. Once they get into the cell, what happens? Okay, the one that gets into the cell faster actually has got to be reconverted within the cell into a folate derivative. The one that gets in slower doesn't have to be converted at all. So there is no faster time to initiating treatment with folate, folinic acid, or folic acid. They all interconvert into the same molecular derivative that then moves into functionality. Okay, so I'm going to say this once again. Basically, which one you choose pretty much doesn't matter. Why you use it is what matters. Now, by the way, that was actually studied by pharmaceutical agencies. Okay, so we're not saying this is Dr. Mensah's opinion. I want to share with you facts. And the fact is the folate derivatives all interconvert. And so from a rate limiting step, when you go to enzyme kinetics, the rate limiting step in those changes basically allows them to all function at the same rate. There is no one faster than the other, and there is no one better than the other in general. Now, we're not talking about autism. We're talking about adults here. Autism is a little bit different. So the other piece becomes, are you using folic acid or folinic acid or folate to treat a genetic SNP like MTHFR? If you do, you're moving in the wrong direction, unless you know for sure that the chemistry is there. So let me give you an idea. You're treating a SNP for MTHFR, but your chemistry says this person is over methylated, not under methylated, over methylated. Guess what? If you give any of those folate derivatives, it's going to work pretty well, because that's exactly how you treat over methylation. But if you give someone who is truly under methylated any one of those 3 derivatives, and let's add methylated folate in there as well. If you give methylated folate, you will see a temporary increase in improvement for the patient that lasts approximately 3 months. And then that patient will decline. Well, you say, Dr. Mensah, why is that? Well, I'm glad you asked. Let me tell you. Because when we look at the absolute methylation pathway, we have the primary pathway starting with methionine. And then we have the secondary pathway, which is the folate pathway and tetrahydrobiopterin in the center. Well, folates push the secondary pathway, which is faster and more powerful. It's faster. So you get a temporary upswing in how the patient is behaving or responding. But then over time, what it's doing is that it's stealing methyl from your DNA. And so after 3 months, the backup pathway, which is the faster pathway, has got no backup left. You burned it out. Okay. But the primary pathway is still lagging because you didn't give it the true methyl donors that an undermethylated person needs. Okay. So that's a very quick summary. But the point here is if you're truly undermethylated, you don't use a folate derivative, whether it's folic acid, folinic acid, or methylated folate. If you're overmethylated, those are the exact agents that you use. Okay. So the key is not looking at SNPs per se. The key is, if you're going to look at SNPs, make sure you test the chemistry. We use a whole blood histamine test. The best one is from DHA, Direct Health Access Labs. Whole blood histamine will give you a great understanding as to whether or not a person is undermethylated, normal, or overmethylated. Now, for those of you who are really intense, I know what you're thinking. Well, can't that be affected by antihistamines? The answer is yes. The whole blood histamine test does have one weakness. That is antihistamine use. Strong antihistamines, which include SSRIs, which include SNRIs, those are actually strongly antihistaminic. They will actually lower the histamine level artificially. So it's still a good screening test. But let's say your patient is on Seroquel, been on Geodon, and a few others. What you do then is you do the methylation profile test. That will tell you what the system is actually doing, and it's not susceptible to antihistamines. Okay, so anyway, that's the longer, shorter version of the answer there.
We love it. Thanks for the plug there. Whole blood histamine is a part of all of our standard brand chemistry panels that are most commonly ordered by our practitioners at DHA. So it's something that we always promote as far as checking methylation status, and it is super important. So along with that, you answered most of this, but I don't want this person's question to go without being answered. If you wanted to add anything else, how common is it to be undermethylated and do poorly on folate, folic acid due to low serotonin activity? I've heard Dr. Walsh say that most kids with autism are undermethylated, but do very well with folate, and undermethylated patients with low serotonin should avoid folate. How can you tell which undermethylated kids or adults with mood and focus issues should avoid folate? Do you have anything to add there? Because you answered it mostly.
Yes, absolutely. First of all, I know Dr. Walsh very well. He trained me. We put together a lot of paradigms and programs together, but we've seen thousands and thousands, literally, of undermethylated children. And here's the key. The vast majority, more than 85%, don't fall in that category. They are mostly undermethylated individuals, and they typically don't respond well to folates. That's the vast majority. So statistically, if you see an undermethylated child with autism, start them with methionine or TMG, okay? Those are the key methylating donors that you want to give. Very rarely do we have actually an undermethylated individual who is going to respond well to folates or folinic acid. That may be a decent small boost in the secondary pathway, but not in the primary pathway. And then I forgot there was a second part to that question, Caitlin. What was the last thing you mentioned there?
Oh my gosh, let me pull it up. How can you tell which undermethylated kids or adults with mood and focus issues should avoid folate?
Okay, it was about low serotonin activity. That's what I remember. Okay.
Yes,
so,
yes.
So here's the simple point. You guys are way too smart out there. Let me show you the simplicity. Remember what methyl molecules do in the first place. Methyl molecules activate and inactivate enzymes, hormones, and neurotransmitters. So if you have somebody who is truly undermethylated, they're going to have low activity because you don't have enough methyl molecules to turn on your neurotransmitters. Okay, that's the vast majority of individuals. Now, sometimes, unfortunately, it's a little bit of trial and error. On rare occasion, you get individuals who are not responding very well. Now, here's another thing. You can try SAMe for those individuals who may seem to be slow responders. If they're not responding to the SAMe, then it's possible that they're way too depleted, and you might actually try giving TMG or giving actually folic acid to build up or to rev up the secondary support pathway. But eventually you'll wean off that acid or folates. And then responsiveness, it's about statistics, is to see if they really match undermethylation or over. So there are a few different variables there, but most people are actually most people are actually low acting serotonin individuals, in addition to low production serotonin individuals with anxiety, depression, and schizophrenia. So it's a safe bet just to go ahead with the true methylating agents, the methionines, the SAMEs, the TMGs for children, that pathway.
Thanks, Dr. Mensah. That was great. We have a couple questions coming in about the copper IUD. This is a fun one. So, is there any research on the effects of copper levels in women with the copper IUD and increased anxiety? And what do you think about using that versus just a normal hormonal IUD?
Oh, we get that one a lot, and we've seen
Yes.
a lot. Let me tell you something, doctors, OB-GYNs, family practitioners out there. If you have a patient, I want you to remember this, 40% of all females are estrogen dominant. 40%. What does that mean as far as copper is concerned? Copper responds to estrogen. When estrogen levels go up, copper levels go up. That's why you see the mood swings with regard to the monthly cycle in these females, right? Because when copper goes up, it now turns dopamine into norepinephrine. Norepinephrine in the adrenal gland will cause adrenal fatigue, and you'll start to see depression and mood swings. I want you to use that as a base, right? Number 40%. So when you see a female and she comes in and she's telling you she's got these issues and she wants to say start on birth control, one of the first things you really need to do, check that copper level, okay? Call DHA, order the testing for copper, and I would actually check copper and ceruloplasmin, because you would need to do a percent-free copper test, because percent-free copper can be really damaging even in the presence of what looks like a normal total copper level. So that's a calculation that's done that requires ceruloplasmin, okay? But when you've got a high copper female, the last thing you want to do is to add a copper IUD to the patient. We're dealing with a case literally just 2 days ago when a young lady called in, and it was actually her mother, who stated that when she started the copper IUD, her world turned totally upside down and horrific. Now, she looked like she had a typical normal copper level. But what we oftentimes forget is that the role of a mechanical device, a structural device in the uterus, creates inflammation. Now, somebody who's hypersensitive, in general, when they have a device that creates inflammation implanted in their system, it's like a domino effect. The inflammation doesn't stay local. It can spread throughout the entire body. We've seen it on several occasions. So typically speaking, something like an IUD is not our choice when it comes to contraception. But if it is something you want to go with, first check the copper level, check the ceruloplasmin level, do the calculation, and make sure that there is not an elevated percent-free copper. Because not only can that be a problem now, that can be a problem later on in life with issues like ovarian cysts, fibroids, endometriosis, breast cancer in the family. Doesn't have to be in that person, in the family. So do a little bit of a family history. Find out if the young lady has got any relatives, sisters, cousins, mostly sisters, moms, aunts, grandparents, females, with any of those past conditions. If they do, that's a sign that they're estrogen dominant and copper toxic, or they have a strong tendency toward copper toxicity, and then stay away from the copper IUD. It just wreaks havoc in many a young lady.
Thanks, Dr. Mensah. Speaking of copper, so increased estrogen or estrogen overload causes copper retention. Does the inverse apply, meaning would elevated testosterone decrease copper? That was a question from Kate.
And that's a great question. The answer is no, it does not. No, it does not. So someone sounds like they're working with hormone therapy, right? HRT,
Yes.
hormone replacement therapy. So when you give estrogen and progesterone, estrogen and testosterone, the hormones may be more balanced, but the system doesn't care. Copper's devoted to estrogen. They're so close. They're loving one another. The copper is not going to pay attention to any other hormone other than estrogen. When estrogen levels go down, copper will go down. When estrogen levels go up, copper levels go up. It doesn't matter what other hormone you're giving, okay? So you've got to be careful. If it's HRT, once again, check your patients to make sure that they don't have a family history of any of those things we talked about, breast cancer, fibroids, endometriosis. Otherwise, it doesn't matter what other hormone you're going to give. it's not going to cancel out the copper. It is not.
Awesome. Thanks. I had one from Sandra. Do you like the copper zinc test by Mosaic?
I'm not as familiar with that one, but here's the problem. A lot of these folks, a lot of these companies are not checking the proper type of zinc. They're using whole blood zinc. You've got to use plasma zinc. And what I would do if you're not sure, it's a very simple test. Order the copper zinc test from DHA, compare it in the same patient to the copper zinc test from Mosaic. And if you're getting similar results, then it's probably an okay test to use. But I like the strong consistency with Direct Health Access Labs. I don't use any other laboratory because I've seen what hospitals will do even when they try to draw a plasma zinc. Quick story, we had one young lady who brought in her child. She was actually a phlebotomist. And we're in a small town called Sterling, Illinois, Community General Hospital. And her child had a behavior disorder. Very typical. We've seen that stuff before. And what happened was that I said, we need a serum copper plasma zinc. So she said, I drew this myself. I looked at the results. They're perfectly normal. I said, this is not right. We went through this. She said she had drawn it herself. She was sure she knew for a fact these levels could not be. The test results were total. I said, now that's the proper test result. Okay. So I'm not going to say that no test is absolutely horrible and no test is absolutely superior, but I like the consistency of DHA. And that's the testing process that I would suggest, especially if you're just getting started in this.
I appreciate that, Dr. Mensah. Sometimes practitioners aren't here, and we have one, Nicola, who's saying, I'm in Canada and we aren't able to get the blood draw here for the whole blood histamine test. Is there a dried blood spot option that you think is good for whole blood histamine? I know you got to answer it though.
Yeah, no, there really isn't.
Unfortunately, yeah.
And it is the more, I would say, financially appropriate starting point for methylation testing. But if you can't do that, then there's the methylation profile that you can look to order. And that will at least tell you what the patient's body is doing. And I want to share with all the practitioners out there, there's a difference between how you were designed versus what your body is doing. The whole blood histamine test tells you how you were actually designed. The methylation profile will tell you what your body is doing. So if a patient has been supplementing on their own because they read Dr. Walsh's book or they, saw videos and so forth, and they're taking supplements, they can actually change what the methylation profile shows up as, but they wouldn't change what the histamine test is showing up as. Okay, that's the difference. There's how you're designed, and then there's how your body actually is working at that time. So if you can't get the whole blood histamine test, try the methylation profile.
Oh, that's great. So with that whole blood histamine test and as well as the SAM-E SAW ratio test, are those lab ranges valid or are you using some specific functional range for those tests when you're looking at patient cases?
So we've been talking to Direct Health about this quite a while. We use the Walsh-Pfeiffer-Mensah range. Okay. And that's the range that is on the test if you request it. That determines what pathological boundaries we're looking at. So for us, for example, let's look at zinc, right? We're looking at a zinc range between 90 and up. So above 90, your zinc level is pretty decent. Below 90, it's low. Now, when you look at many of the generic test results, they give you a wide range. And that range is basically from the lowest test they've seen to the highest test number they've seen. But it's not standardized to pathology, in particular mental health pathology. That's why we use very specific ranges, and DHA is aware of those. So, for example, zinc, one more time, above 90, that's wonderful. Below 90, problems. Moderate range is below is 75 to 80. Extremely low is 60. I don't even know how some people are surviving with a 60 level of zinc for everything that zinc does. And remember, there are over 250 chemical reactions that zinc is key for. Everything from your mood and neurotransmitter production to, remember this one, guys, go back in time to first year med school, repairing DNA. The enzyme DNA ligase requires zinc in order to function. So if you're low in zinc, you are not going to be able to repair your DNA. And that's why, in part, you see aging in people who are not eating very well. You see it much more intensely in individuals who have a poor dietary regimen, or when people lose sort of that sense of smell, as you do when you get older, and sense of taste. They eat less, they're eating less zinc, they age more. So that's one for you out there. If you want to do your anti-aging homework, start with zinc.
I think we all want some anti-aging, so we're all gonna run to zinc on that one. So I got a question from Tina who submitted it before because she couldn't be here tonight. I'm gonna combine that with another question so that you can kind of answer them as one. Dr. Mensah, do you recommend any micronutrient testing or HTMA testing? And could you tell us about your top 5 lab tests that are across the board helpful in your patient cases, and maybe some of the more esoteric tests that are used on more of a per patient basis? So I think it's really which tests are you running on all your clients and patients, and which ones are you kind of selecting from a menu to give them more specialized testing and care?
Okay, those are loaded questions because
I know.
our,
I'm sorry.
our main piece is bio-individuality. Okay, so when a professional athlete comes to us, we order a different set of tests. Now, let's start with the foundation. Every person who comes in gets a zinc, copper, histamine, vitamin D, thyroid test, and depending on age, maybe a homocysteine, plus a few others. So those are the main, big boys and girls, okay, in our testing process. Now, individuals who've got challenges like, say, OCD, ADHD, gut malabsorption, gut issues, we're also going to do a hair analysis. Okay. Now, our hair analysis is not looking for metals in terms of metal toxicity. We actually look at patterns that are seen in the hair analysis. Okay. So we have to be very, very careful. And I want to say there's some misinformation out there. You cannot tell what somebody's copper level is by doing a hair analysis. That is, I saw it on the internet, it enraged me. It is absolutely wrong. Hair is an excretory product. What you see in hair is what the body is getting rid of, not what is present inside the body. So that's a big thing. I want you guys to understand that. So you cannot substitute a hair analysis for a copper level, okay? Now, when we have children with autism, for example, we'll do quite a bit of gut testing too, okay? And that can come in various forms. Do we do micronutrient testing? Yes, we do, okay? But now, are you going to do, for example, a GI map in everybody? Well, no, but you'll do a GI map in individuals who have, in addition to anxiety and depression, individuals who may have not just constipation and diarrhea, but irritable bowel syndrome or inflammatory bowel conditions that are present throughout the family. And they tell you, my bowels just haven't been right. I have lots of gas, et cetera, et cetera. There are a plethora of tests that are available. But the key ones are sort of the ones we mentioned before. You start with your copper, zinc, histamine, vitamin D, TSH, homocysteine levels, and those kinds of things, because they give you a good solid foundation as to what's going on in terms of mental health. Now, when we move into other dysregulatory patterns, that's a different story. Again, with our professional athletes, we may actually order an amino acid panel in addition to those tests. But we're looking for different things, and depending on the type of athlete, we treat a soccer player differently than we treat a football player. We treat a baseball player different than we treat the other ones as well. Their dietary recommendations are also very different. So when we're sticking truly with just pathology, a child is not an adult. We will order different lab tests. We'll have a different focus and function for a child with challenges versus an adult who may have similar. So even childhood schizophrenia versus adult schizophrenia, same basic concepts, but different fine-tuning laboratories.
Great, Menza, that was amazing. How does seizure activity or epilepsy impact the activation or deactivation of neurotransmitter activity and an individual's biochemistry suffering from anxiety, depression?
Okay, so I want to reverse those concepts. Okay, it's not the seizure disorder affecting the chemistry, it's the chemistry affecting the seizure disorder. Simple example, we've been talking about copper. What is copper? It's an excitatory agent. Go back to biochemistry, go back to college or med school, wherever you learned your chemistry, right? Copper has a +2 charge. It's a charged particle. Charge isn't there just for fluff. Charge means that when it attaches itself to a nerve cell, it's going to hyperstimulate that nerve cell. So there's a second pathway beyond just neurotransmission as far as, say, the development of norepinephrine from dopamine because of copper. Copper literally attaches itself to nerve cells and stimulates those nerve cells. So if you've got a child or a person who's got seizure activity, you definitely want to minimize copper in diet, but you check them as far as their copper levels are concerned as well and treat that. Okay, that's part one. Part two, where you guys haven't gotten yet, but you will hopefully in the next 5 years, school will be talking about it. Voltage. Okay, agents like copper change the voltage pathways in the system at the cellular membrane level. And when you have a change in those pathways, what you're doing is you're lowering the seizure threshold or you're raising the seizure threshold depending on the nutrients you take. So I'm going to give you a few quick ones. Any child or any adult who's got a seizure disorder should not be taking manganese, manganese. I'm going to say it one more time. Manganese lowers the seizure threshold. Why am I bringing it up? Folks, take a look at any multivitamin over the counter. You're going to see manganese in there. And you'll say, oh, but Dr. Mensah, it's only 1 or 2 milligrams of manganese. Let me tell you, manganese is like nitroglycerin. It only takes a drop to cause the entire house to explode. No exaggeration. You see 1 milligram of manganese, that's enough to put a child into seizure activity. 2 milligrams, 3 milligrams, enough to put an adult into seizure activity. Okay? So caution around that agent. Manganese, not your friend, but it's everywhere. It's really ubiquitous. Okay. So now what you want to do are give agents actually that tend to lower the voltage, which means you actually increase, believe it or not, you increase the resistance to seizure activity. And that's where nutrients like zinc actually come into play. Like I said, I'm giving you a little bit of insight into the future of our discussions in medical science. The other side of nutrient therapy, what it does to cellular membrane activity. Lithium, most of you recognize lithium as being a cellular membrane stabilizer. It is, but lithium is a metal, right? But it's one that actually will decrease the potential for seizure activity. So that's a whole discussion I'd love to have with whoever's asking that question a little bit more in depth, because there are a lot of factors that come into seizures that we have to be cautious of, okay? And that it means big on diet. We have to be very cautious of the diet for the patient because oftentimes we're giving them so many of these so-called good foods, and what we find out is that those are not good for seizure activity. They can actually make it worse. So I hope I didn't get lost in all this verbosity here and not answer the question. If we didn't, I'll circle right back around it and get it to it directly. Ooh, I think I lost the sound here.
Oh, sorry, that was totally on me. Thanks. We can circle back. People are just continuing to submit questions, which I love. And I wanted to point out that one thing that you just said was that you practitioners could potentially speak with you and consult with you. So when you are ordering DHA labs, any brain chemistry panels, you are able to schedule a consultation with Dr. Mensah for free over the phone if you are a trained physician. So that is a huge benefit of ordering testing through us. And I wanted to call that out because to me, you seem so, untouchable because you're Dr. Mensah. And we're just happy that we are able to partner our practitioners with the best possible physicians. And you're one of them.
Oh, thank you, Caitlin.
You're welcome. I'm going to flip the script a little bit here, and I want to talk about the gut brain. So where does the gut brain connection come into play here? And do you see skin issues and or other symptoms and complaints that we would generally not assume are related clear up in your patients when addressing the core tests like copper, zinc, methylation, pyrroles, etc.?
Absolutely. So first of all, the gut and the brain are always connected. You know, for many it's a new concept. For others, it's old hat. But there's some things that's just such a huge subject. But I want to kind of say, first of all, you know, especially in children. I'll just say one thing about kids. For example, we don't think about yeast very much in children. Okay, or in adults, we say, oh, well, that's mostly a gynecologic thing, or it's a dermatologic thing. Well, yeast in the gut can lead to ADHD type behaviors in children. Yeast in the gut can lead to violent behavior in children. If a child comes in anywhere between 5 and 9 years of age and has enuresis or bedwetting, especially a male, check for yeast in the gut. The vast majority of the time, that actually is the culprit. Why?
Wow.
Because we're talking about not just one little yeast agent, it's the covering. It is the chemicals that are released. It is the biofilm that's created in the gut. It is now producing leaky gut type issues. So the toxins they release get into the bloodstream and travel not just from through the gut, but from the gut to the brain and other parts of the body. Joint aches, joint pains, inflammation, a lot of that is actually related to yeast. That's only one example of how the microbiome can affect the brain. So there's a whole lot of connections there. Everything from how many species, different species of Campylobacter, species of Saprophyticus, a variety of agents in the gut. It's huge, but it's called balance. And it's called getting rid of the bad stuff, reseeding, and then allowing the good stuff to grow. But it's a very, very complicated issue, but there's a huge connection. One thing I want to make sure people understand, many people will say that the gut is the major source of serotonin in the body. And I want to say that's wrong. There are two different biosynthetic pathways for serotonin. One is in the brain and one is in the gut. And he's saying, well, that's not what I've been told, Dr. Mensah. Well, let me share with you this. Let's just forget all this science stuff and use common sense. The brain and the body is highly efficient, okay? We've got serotonin that needs to be in both places. Wouldn't it make more sense for serotonin to be produced locally as opposed to being produced somewhere far and then shipped somewhere else? Okay. So you've got 32 feet of bowel, 32 feet of bowel. And that bowel is moved by nerves. That's what the neural plexus is around the colon. Each one of those nerves requires neurotransmitters. That's where the serotonin is coming from to allow your gut to actually have peristalsis and to move. And so the serotonin that's in the gut stays in the gut. It's what moves the gut and allows it to be functional. The serotonin that's in the brain stays in the brain. It doesn't travel. And they are made in two very different ways and two very different pathways. So I wanted to make sure folks understood that. But still, there is still that connection by way of enzymes, hormones, and so forth that move from the gut to the brain and from the brain to the gut. Otherwise, you would not freak out and feel that sensation in your gut when something hits your brain in terms of anxiety, depression, and all of a sudden it manifests psychosomatically in the body. So there is a connection, but I just wanted people to understand it's not a one size simplicity such as, well, the serotonin's in the gut and it travels all over the place. That's not the issue at all. Okay.
But that's good to know, Dr. Mensah. I have another gut question here from Tatiana, who recently trained with Dr. Walsh, and she's wanting to begin implementing the protocols with patients, but she doesn't know about the gut part so much. Could you review some dietary changes recommended in different types of issues, or what testing she would use to do that? I see you smiling. This is a good
Yeah,
one, huh?
I love this one because many people don't realize. I'm going to tell you guys, look, this world of orthomolecular is about throwing away all of your preconceived notions. I mentored Dr. Walsh when he first met me. He said, Albert, you know, a real scientist is willing to throw away his most or her most cherished feelings and thoughts and ideas when presented with different evidence. Okay. So I want to share with you something. Vegetables are great for your body. They may not be great for your brain. Meat may be great for your body, but it may not be great for your brain. What's the difference? I always say who you are. The first thing to do is identify your methylation status. That's why I harp on methylation so much. Your methylation status determines how you should be eating in terms of the foods and the food choices you make. Guess what? Most undermethylated people love dark green leafy vegetables. But dark green leafy vegetables are so often high in folates that the more dark greens they eat, the more depressed and anxious they become, and they don't realize it. And so they'll start with eating clean, then they'll start with becoming a vegetarian, and they're not better, they're actually worse. So they figure they're going to become vegans. So they say, oh my goodness, I'm still not better, I'm actually worse. And they don't realize, as an undermethylator, the dark green leafy vegetables they're eating are high in folates. Folates steal methyl from your system, from your DNA, the cellular level in the nucleus of the cell, DNA. It takes away your methyl molecules. So what should you really be eating as an undermethylator? More meat. Here's the other side of the equation. And remember, the more methyl you have, the larger your musculature, because methyl molecules turn to creatine. Creatine turns into muscle, right? So all these relatively slight individuals that we see, these are usually the undermethylated folks. And yet they're not eating what it is that gives them more methyl. I want to talk about the other guys. I'm going to say guys specifically for a reason. Those giant walking trees we call football players, okay? Most of them are hugely massive. Most of them are overmethylated, especially the defensive linemen and the offensive linemen. But guess what? They should be eating lots of dark green leafy vegetables. They've got too much methyl. It's not going to affect their growth of musculature, but it affects their processing, and they don't realize it. So it's not that one dietary regimen is better than another. It's that you've got to look at what's best for this person. Are copper toxic females? Guess what? Kale, spinach, broccoli sound familiar? Not your friends if you're copper toxic. Those agents make you worse if you have anxiety, depression, bipolar, schizophrenia, or even ADHD. Okay? So let's make life really complicated. What if you're an undermethylated person and you're copper toxic? Okay? Well, I'll just make a long story short. We once had a family of 5, 3 kids, 2 adults, and we checked their chemistry. And they asked about diet. And I said to them, I'm sorry, the 5 of you cannot sit down at a table and share the same meal. It's not going to work. They all had different combinations of different chemistries that made what's beneficial for one person horrible from another. So in that family, it's called middle of the line. You eat a little bit of these things and you're okay, but you cannot super specialize in them that way. Long story short, here's the deal. If you want to know about what you do for diet, first check methylation status, okay? Undermethylators should have, at least in the worst case scenario, a balance. Stay away from the carbs as usual, but seek the proteins more so than the dark green veggies. You can use lighter veggies or different colored veggies, but the dark green leafy vegetables are usually the ones that are high in folates and high in copper. So those are things you want to try to stay away from, okay? Now, those people who are overmethylated, hey, go cut down the entire garden and feed it to them 3 times a day. They're going to do real well, okay? So it all depends. First, understand your chemistry, and then understand how we at Mensah Medical, as clinicians, not chemists, but as clinicians, approach patient management. You got to look at the whole person. Talk to them about their diet, and I'm sure you all do, but then understand whether or not they're doing the right things based upon their chemistry or not. This is not something genes are going to tell you. This is something the actual chemistry is going to tell you, okay?
Thanks, Dr. Mensah. I'm with you on that. And next time anyone asks me who my nutritionist is, I'm going to say it's Dr. Mensah from Mensah Medical, and he told me to skip the veggies and eat meat. So there we
Well,
go.
I didn't say get rid of veggies total. You just have to
Dark leafy greens.
Right.
All right, so we have 5 more questions, and we thank you for being here this long so far. I do want to mention to everyone who's still with us, at the end of Dr. Mensah's live Q&A, I am going to quickly pull up my screen and show you a QR code. That QR code is going to go to an end of webinar survey that I would really appreciate you fill out. It's 2 questions. It's going to take you less than 30 seconds. And I just wanted to announce it now so that we get as many people as we can to stick on and check that out for me and DHA. So Here we go. Back to Dr. Mensah answering questions. Besides antihistamines, does current use of an SSRI, SNRI affect the whole blood histamine test?
Yes. Um, those two categories of medication are very powerful antihistamines themselves. Okay.
Wow.
So you can just basically bank on it now. Everybody's histamine level is different. All right. So somebody can be on 2 or 3 of those medications and still show up greater than 70, which is our borderline for undermethylation, 70 and above. So the higher than 70 you go, the more undermethylated you are. There's some people who are taking one of those medications and they're testing around a 55, 60, and yet that's masked undermethylation for them. So you've got to look at the whole person, the whole picture. But typically speaking, when you see individuals on either an SSRI, SNRI, or they've got a history of, sound familiar, I've tried 9 or 10 different medications and nothing worked for me. Okay. And you look on the list and they've got all the heavy hitters, Geodon, Seroquel for our schizophrenics, everything from Pristiq to Zoloft to Paxil. All these things are basically saying in succession, we've had a lengthy utilization of these antihistamine meds, meaning your body hasn't had a chance to upregulate at the histamine. And so you're going to likely see a lower level. You've got to modulate that. At that point, you might want to use the methylation profile test when you see a long list of meds like that in the history.
Great. Thanks, Dr. Mensah. We've got a question from Michelle. I work with Dr. Walsh's protocols, and there are times when I titrate up zinc and B6 to address copper levels, but in retesting, copper levels do not come down. Any thoughts on why? We look at where the copper is coming from, diet,
Yeah.
estrogen. What else could be impacting that copper and keeping it from going down?
Yeah, there's a big misnomer out there. Zinc and copper are not exactly 1-to-1. And I've seen this all the time. I hear this all the time. Look, the agents that bring down copper singly, it's not zinc. Okay. The dosages that you use zinc in order to bring down copper can cause a microcytic anemia. You do not want to do that. The real agents you use to bring down copper in an adult are molybdenum or N-acetylcysteine. Okay. Especially for percent-free copper, N-acetylcysteine is just beautiful. And guess what? None of those things will cause an anemia. Why am I saying that? Because you're clinicians out there, and I want you to understand. Scientists, biochemists, they talk about ratios, they talk about numbers. They're not talking about people and patients. Please understand that. They don't have that background. Okay. What we're talking about here is that the real agents that will uniformly bring down copper are, as I said, you cannot use molybdenum, by the way, in a child because it can stunt their growth. So you don't use molybdenum in a child. Use NAC. What you'd use for adults, you can use molybdenum, NAC. And of course, yes, you're going to use some zinc because that's part of the protocol for a variety of other reasons. But the reason you're failing is because you're not directly utilizing a copper decreasing agent. It's not powerful enough by itself. Zinc I'm talking about. Okay. So if you're just wondering about copper, go with NAC. Heck, I'll even give you the dosage, 500 milligrams, 1 time a day. Okay. Recheck the copper level in probably about 3 to 6 months. All right. Now, if you use NAC and molybdenum together, beautiful, beautiful results in an adult. Okay. Now, one thing I'll share with you, if that copper starts to rush out too quickly, your patient say, you know what, I'm feeling worse, or like what happened to me, 15 years ago, a patient's husband called me and said, what did you do to my wife? I said, I'm sorry, copper's coming out too fast. We're going to ease up on the intensity of the protocol. Okay. But the reason you're having trouble is because you're not actually using a copper removing agent. Zinc by itself is not going to do that trick. It does not. I know that's what's being told out there. It's not correct. And I've had that conversation with some folks. I won't say who I had that conversation with, and told them that is not correct. Okay. You cannot tell people that. But that's all I'll say.
That brought a question up for myself, actually, Dr. Mensah. I know that you specifically mentioned not using certain supplements in children. I'm wondering if how young can you run these tests on peds? For those practitioners that are working with younger populations, is it an accurate assessment to still be running these same tests on children as well to check their methylation status and their copper, zinc, and all that?
Absolutely. But here's the borderline: age 2 or 30 pounds. Okay.
Okay, that's where it
That's where you
starts.
go. Age 2, absolutely, or 30 pounds. That's when you're pretty confident that what you're doing is very, very accurate. So I'm going to tell you something else. Pregnant women, do not touch pregnant women with these compounds, because you do not know what these things are going to do to the fetus.
Mm,
So that's a cautionary measure. Someone says, I'm planning on getting pregnant. We tell them, well, you have to let us know the moment you know you're pregnant, because then we've
yeah.
got to change everything.
Yeah, that's really valid. Thanks, Dr. Mensah. I know we have a lot of providers that specialize in that field, so that is really great. We only have a couple more questions. Do you have, so Colleen is wondering, I actually learned recently from Dr. Greenblatt that our pyrroles increase during times of stress, which was new to me. She's wondering if you have to have the genetic tendency for pyrrole. So do you have to have pyrrole disorder in order to see increased levels with stress, or is that just person-wide? You're shaking your head like you don't agree with that. So tell me
Yeah.
more.
No, first of all, I love and respect Dr. Greenblatt. He's a wonderful, wonderful fellow. But let me share with you, pyrrole disorder by definition, if you guys don't remember anything from this, pyrrole disorder by definition is a disorder of stress intolerance.
Mm,
You don't get that. It's a vicious cycle, because stress causes pyrroles to rise. And as pyrroles rise, they cause more stress. Why? Because pyrroles deplete you of zinc and B6. What do you need to make your calming neurotransmitters? GABA, for example, zinc and B6. So it becomes a vicious cycle. The more stressed you are, the more pyrroles rise. The more pyrroles rise, the more depleted of zinc and B6 you become. The more depleted you become, the less you're able to make your calming neurotransmitters. And what does that do to your body? It makes it even more stressed. So it raises pyrroles even more. Okay. So it's a vicious cycle. By definition, pyrroles equal stress. What is stress? Physical, physiologic, emotional, biochemical, or environmental. Sorry. For example, environmental, your job. Your mate has made you very irritable after a long day. It can be male or female. Okay. Physiologic. Folks, do you know what the terrible twos are? Most of you are sitting back thinking the terrible twos are normal. They are not normal. They're pathological. Well, then why is it so commonplace, Dr. Mensah? Because the terrible twos is a time of increased physiologic stress and physical stress in a child. Same for the teenage years. Sound familiar? And folks, what are the two time periods in life when we see our children acting absolutely bonkers? The teenage years and the terrible twos. And all of their symptoms go hand in hand with pyrrole disorder. When you treat pyrrole disorder in those two categories, children normalize. Our teens are now people we actually recognize. Okay. So genetics, there is genetic variation to pyroluria or pyrrole disorder. I'm going to share with you something. There are genealogical two genealogical families, if you will, on this entire planet that are basically pyrrole disorder without question. The Celtic groups and the Scandinavian groups. They are born pyrroles. Ever hear about the Fighting Irish? Guess why they're called that? That fiery redhead that you married? Guess what? Pyrrole disorder. That lovely blonde haired, blue eyed little child you've got going on? Pyrrole disorder. Now, anyone can get pyrrole disorder. So it is most often an acquired phenomenon. Well, let's face it, we're not exactly entirely 100% pure in genealogy anymore. Okay? I've got Irish relatives. Shocking, shocking, shocking. Okay? I've got relatives from Scandinavia, believe it or not. Okay? And they don't look like me. So we all have genes that have been mixing over the course of millennia now. So anytime you've got an Irish, Scandinavian ancestor or whatever have you, it means, yes, pyroluria could be flowing through your veins. To answer the question, there are genetic pyrolurics. There are the Scandinavians, and the Scottish, Welsh, um, Scottish individuals. So there's Scottish, Irish, and even English. Okay. So those are the genetic ones. But I want you to remember anybody can get pyroluria. It's only a matter of stress. Stress will cause it. And every single person on this planet has had 2 periods in their lives where they were pyroluric. Every single person.
Wow,
And
thanks
it's
for the
treatable. Urine test. Treat it. It's the simplest chemistry you can treat. Pyro disorder. Simplest.
Wow. Yeah. The one simple urine test really goes a long way. I'm actually going to answer a question that came through, and then I'm going to ask you your final question. So we had a question, how can we get more training? And if we order labs, is there support to help interpret results? Yes. There is more training. I'm actually announcing to DHA's followers next week. If you are here, you're going to get the email. Walsh is releasing a new course that's going to cover a lot of his training techniques and his education. It's available for licensed physicians as well as credentialed practitioners. This is the first time they are ever training individuals who aren't licensed medical professionals, and it's going to be really high level. It's super exciting, and they're doing it because there was such interest in it, and they had to roll it out for so many practitioners. So that's to come. Also, I know Mensa Medical has a mentorship program that we can promote via email as well, Dr. Mensah. And the other question was, is there support to help interpret results? Yes. When you order through us any of our brain chemistry panels, you can book in for a complimentary consultation with either Dr. Susan Delaney or Dr. Mensah, who's in front of us. So depending on the testing you order, depending on your credentials, you get support for every single client order. So every single panel you order, you can book in for a free 30-minute consultation until you don't need it anymore. So I tell practitioners all the time, if you have a tough client, if you have a complex history, if your typical protocols aren't working, book in with one of our consultants and they'll help you. So that's what I got there. And then final question, Tatiana, a round of applause for her. She just asked, I think, the best question so far. I'm a bit confused. Walsh, from what I recall, and you confirmed it sounded like, said it's not really helpful to test for MTHFR SNPs. But Dr. Greenblatt said the opposite and that they must be tested. I need you to expand a bit further on your view so I can have a clear understanding. I think we all can agree on the answer, and I want to hear from you, Dr. Mensah, how you can articulate this, because it can be really challenging, especially when practitioners just aren't able to, dive through every single leader in the industry and all of the education and science they're pushing forward.
Well, I don't like to talk about other practitioners in particular. Okay. I have a lot of respect for Dr. Greenblatt. What I like to share with people, though, is what we can talk about what we do. Okay. We are leaders in the field. We didn't acquire this information. We helped pioneer this information. We've seen thousands of patients with methylation disorders, et cetera, et cetera, et cetera. And the simple facts are, I could put this in a very cheeky sort of way. Well, you can try things that way and see if it works for you. If it doesn't work for you, then try things this way. Okay. But the truth of the matter is that no, the whole idea behind SNPs is absolutely challenging. And if we had more time, I'd really get into it. But I'm going to share with you a few things. I want people to start thinking about actual genetics and actual biochemistry and what SNPs are. Most SNPs in your body actually have no effect on you. I want you to understand that. Most SNPs do not. Any physician will know. Right now, we all sit with 5 lethal genes in our bodies. 5. If any one of those genes turns on, we would drop dead immediately. 5 lethal genes. How long has the human race been around? Okay. So if you do genetic testing, it says, well, you've got this lethal gene. Is it active? No. Is it going to be active? Not really. Okay. So genes and SNPs don't tell you the story. The other thing is you've got to look at the size of the molecule that the SNP is affecting. The larger the molecule, the less effect any SNP has. Now, all of our people are thinking about biochemistry now. They go, oh, yeah, I think I remember that in med school. Okay. But the deal is something like MTHFR is a huge enzyme. It's huge. It's like saying you're driving a car that has 10,000 wheels on it, and one SNP takes out one wheel. Is that going to stop the car? No. Two SNPs takes out both wheels. Now you're homozygous. And guess what? You still have 999,998 wheels in this vehicle. Okay? So SNPs depend on the size of the enzyme. They depend on the molecular weight of the enzyme. They depend on the acid-base situation. But when you're talking about MTHFR, it's such a huge molecule that being homozygous has literally no meaning. None. It does not affect the activity of the MTHFR enzyme. Now, I want to give you a little bit of history about that, what other folks don't know. Dr. Amy Yasko, brilliant young lady, brilliant, brilliant, brilliant. She's the one who came up with the whole MTHFR concept, but she had never heard of methylation until she met Dr. Walsh. And Dr. Walsh told her she was moving in the wrong direction in her development of MTHFR. She's a pediatrician, and he said things are different after birth than before. But she went on, came up with this, got popularized, but the fact is, proof is in the pudding. Most people who use the MTHFR pathway don't get any results. And they're wondering why not. They've tried the methylated folate, they've tried folic acid. It doesn't work in the vast majority of people. Like I said earlier, it will boost you up for about 3 months, and then it causes you to crash because it's the backup pathway that is stimulating, not the primary pathway. Okay. So we can all disagree. We're not, listen, we all have our strengths, we all have our challenges, but we're pretty good with methylation. And so let's just say that's all I'll say about that.
Love it, Dr. Mensah. Thank you so much. We are so grateful that we had you tonight for our first official webinar of our series. And you got through over 40 questions in an hour. I think that's absolutely a world record. And I can't think of a better physician to start us off. So I just want to ask everyone to stay on for a second. I'm going to share my screen for exactly 1 minute. And you'll see this QR code here, and let me see in chat if you can't see it. Please just take a look at this QR code. This is a 2-question survey. It's going to take you less than 60 seconds to fill it out. We really value your feedback as a provider, and I want to know how I did, honestly. So please tell me how Dr. Mensah did. Please tell me how everything went, and we will be in touch about our next webinar series. It's going to come very soon, and we just cannot wait. So I'm going to leave this up here for another minute and hope that, yeah, look at this, Dr. Mensah. Yeah, so guys, I'm putting the link into the chat too. So we have so many comments. This was excellent from Melissa. Thanks so much. Very helpful from somebody else. We have the link in chat in the survey, and we are just so thankful that Dr. Mensah is here with us today and was able to chat with us. All right, I think that's good. I think that's all we got, Dr. Mensah.
Thank you very much, Caitlin. Appreciate it. And thank you everyone for attending and listening and putting up with all of my hyperverbalizations.
Everyone keeps just saying, thank you, thank you, thank you, thank you. So helpful. Thanks, guys. Please take that survey. I really need your help. All of you. Thanks, Melissa. Bye, you guys. Have a great night.